Our final speaker is going to give us a view from a healthcare perspective, and he has a vast experience from that perspective. He is currently the Senior Vice President of the Medicine Service Line and Chair of the Department of Medicine at Northwell Health. Before that, he held senior leadership roles in Cornell's Biomedical Research Division, as well as the University of Pennsylvania, and his own research on the racial and ethnic variations in the use of knee and hip replacements in the management of end-stage osteoarthritis has been funded for more than 20 years. Will you please welcome Dr. Said Ibrahim. Over to you, Said.
Good morning. Good morning. We need to wake up a little bit. First of all, thank you for having me. Thanks again to Peter and the team who really sort of organized this amazing talk. Let me start with just an outline. Well, first of all, a little bit of disclosure. Unfortunately or fortunately, I have no financial sort of conflicts to share with you. I also wanted to make sure that I declare myself clearly that I am 6'8" tall and still growing. just in case you were wondering. And lastly, I do have an accent, and my accent is not from Donegal, and it's not from New York. My accent is from East Africa. I'm actually a Somali, where in the old days the English used to call us the Irish of Africa. And why did they say that? That's a subject for another day. So I know time is of the essence, and I have a flight to catch in Dublin at 5 o'clock, so I probably should speak fast if I can. I will say a few things about myself, because I think where I come from actually shapes a little bit about my views about research in general and science. And then I would like to say a few words about Northwell Health, which some of you may know a little bit about. I think you have met our esteemed leader and CEO who was here not long ago. And I will sort of say a few things about our institutes for research, which actually will resonate with the whole mission, sort of a reason why we're here today. And then two words about what is the perspective of health systems, on research. And finally, and this is actually what I usually give for an hour-long conversation, is the work that myself and my team have done over the last 20 years, as a case example of how a health system question really leads to research and uses all types of research, including clinical trials, to answer the question. So with that, let me first just quickly give you where I have been, both as a student as well as a researcher in the last probably 25, 30 years. So I started out, after I left East Africa for the United States, at a small little college called Oberlin in Ohio. It's a liberal arts school, and that's where I actually met my wife of 36 years, who's not here this morning, but is with me here in Ireland because she has relatives in Donegal, so she wanted to make sure that she said hello to her relatives before we go back to New York. And then before I went to medical school, I spent some time at the Worcester Institute. Some of you may know about this. This is the oldest biomedical institute, private biomedical institute in the United States. It's right on the campus of the University of Pennsylvania in Philadelphia. This was my job was to sequence DNAs before we had the PCR technology. This is the good old days. But what I think that sort of experience did for me was really sort of helped me understand how science works. And then my wife and I both went to medical school at Case Western School of Medicine. That's where we spent 4 years of our time. And then I did my residency training in internal medicine at the Brigham and Women's Hospital at Harvard Medical School, where I spent a little bit of time learning how to do research. And I was then recruited to University of Pittsburgh, where I established myself as a physician, scientist, NIH-funded one, and then was recruited to University of Pennsylvania, where I was the chief of medicine at the Philadelphia VA and the director of a National Health Services Research Center. And then I took a little bit of a detour, what I call professional midlife crisis. I went to MIT and got an MBA just to understand how the healthcare system works. And then I was recruited to Cornell in the Upper East Side of New York, where I was sort of part of the dean's team to build sort of a more broader research portfolio and to include community as part of the research team. And finally, I am here at Northwell, which is where I come to you this morning. Northwell is a really interesting healthcare system. You've probably met Michael Dowling, who's a fine son of Ireland, who is actually probably, I would say, the #1, the best CEO in healthcare in the United States today. And I may be a little bit biased in favor of Michael, but I definitely believe so. He's a highly visionary man, and he's the one who actually recommended that I should come and join you today here. But what is Northwell? It's the largest healthcare system in New York City, which, as many of you know, New York is the largest city in the United States. And this is a sort of a picture of the different, the 23 hospitals that collectively make what we call Northwell. And I think, when Michael was hired about 30 years ago, he was hired to one of these hospitals. And it was his vision and his sort of really tenacity to really bring together and create the largest healthcare system in the state of New York and in New York over 30 years, which is quite remarkable. This is just one of the ways that you know how important you are in a healthcare, in a region is your market share. And this is really a sort of a quick look at the market share for Northwell in New York. And as you could see, there are some really heavy hitters. New York Presbyterian, which is Cornell and Columbia combined, NYU, which is a very sort of a dynamic healthcare system, Mount Sinai. But Northwell is actually holds the largest market share in New York. And not only that, but it actually accounts for the vast majority of active acute beds in the New York area. Where do our patients come from? They come from all over New York, but one of the most remarkable things about Northwell is that, just to give you an example, the hospital where my office is, the Long Island Jewish Medical Center, takes care of patients primarily from Queens, where almost 160 different languages are spoken. So it's a really sort of a phenomenal sort of healthcare system that sort of takes care of not only sort of the rich and the well-to-do, but also a vast majority of the immigrants and disenfranchised communities in New York. Oops. I think I'm having a build problem here. It is. So we have, of course, the largest number of physicians, as you can imagine, over 4,000 doctors in the health system. About a quarter of them are actually in my department of medicine, which is the largest department in the health system. One of the things that I think Northwell is really unique about is their understanding of the relationship between healthcare and what we need to do for the community. So this is really Northwell's population health sort of a vision. And this is entirely Michael's really vision of making sure that the health system actually takes care of the community, not just the patients who come to the hospital for care, but actually meet patients up front and what we call upstream to make sure that we take care of the social determinants of health, which really shape disease and illness in many ways. So we do most of our research at an institute called the Feinstein Institute, which is really the home of research for the Northwell Health System. And it is a sort of an institute that has probably the same sort of vision and ideas as just like we have been talking about today, and the vision that this Institute of Clinical Trials probably shares. It is an institute of institutes, and as you can see, there are multiple institutes within the institute, and each one of them focuses on a sort of a specific line of research. I happen to be at the Institute for Health Systems Science. That's where my research home is. but we have other institutes. The health system spends $175 million a year to support this institute. So this really is actually a very small investment, if you think about it, for a $16 billion sort of health system. But I think this is a significant amount of investment, and as you could see, clinical trials almost consume $16 million of that. Feinstein is becoming a really high-profile sort of research venue in the New York area, and these are examples of some of the coverage that they have been receiving as of lately. So just a few words about what's in it for the health systems to support research. I think it's important to realize that research helps to ensure the healthcare systems develop novel and sort of approaches and transformative solutions that will improve patients. Here are some of the ways that the health system should actually sort of engage in research. One of them is in evidence-based practice. That takes some research to really sort of make sure that we are delivering the right care to the right patients at the right time. Quality improvement requires some element of research, and that's really sort of important to the health system. Otherwise, the health system cannot improve the care that it delivers. Innovation, cost effectiveness, these are all kinds of things health systems are interested in. These are examples outside of the bench or basic science research what health systems should think about. They have the ability to help do research for prevention and detection of diseases, treatment of chronic diseases, personalized medicine, healthcare infrastructure and delivery, so on and so on. So the health system really has a vested interest in supporting research. But what's in it for the health system? Well, I think what's in it for it is all these things that are important to it, but more importantly, it's becoming a brand issue. Patients in the future will be going to the health systems that they think are the best. And one of the ways to really sort of define what best is the ability to be engaged in research. So let me sort of quickly, really, this is a 25-year-old kind of a project, NIH funded, but I just want to use this as an example of a specific healthcare question that I came across 20 years ago and what we have done to sort of understand. So it turns out that joint replacement use, when you run out of your knees and hips, many of you know that you undergo one potential option is to sort of have knee replacement. It turns out that the use of knee and hip replacement in the management of end-stage osteoarthritis is highly variable in the United States. It varies from region to region, it varies by gender, but the greatest variation is between ethnic groups and African Americans, just to give you an example, are about at least 40% less likely to undergo this treatment. So we wanted to understand, this is a huge sort of health disparity issue. So we wanted to understand why that is. And of course, one of the ways that you could sort of conduct a health disparities research is to follow this sequence of events, which is first you use large databases and to understand exactly what the problem is, what the disparity is. And then you sort of conduct what's called second-generation health disparities research, which the idea being, now that you know what the problem is, you can try to figure out what is the sort of the source of the, what's the mechanism by which this is happening. And then the third generation is to actually use clinical trials to sort of test some solutions. So the work that I'm going to go through very quickly actually tracks this sort of a model. But what is the clinical issue? Osteoarthritis of the knee and hip are very prevalent. They are the most common type of arthritis, and it is actually the leading cause of disability among the elderly in the United States and globally. There is no cure for osteoarthritis, all of you know that. So when all else fails, joint replacement is really sort of the right treatment. In the right hands, with the right sort of health system, it's the right thing to do. But is it effective? Yes, it's been a subject of study for numerous sort of different consensus statements by ARC and the NIH. It's cost effective. because it's associated with less than 10K per quality adjusted life year. More than 90% of the patients who undergo joint replacement are really sort of report improvement in pain and function. It's considered one of the safest surgical procedures in the history of surgery, with less than 1% risk of mortality. And with the advancing technology, a joint prosthesis can last up to 20 to 25 years. So this sounds too good to be true. So what's the problem? The problem is the use of the treatment, which is actually expanding globally, not just in the United States. This is a figure for the Medicare patients, projected to 2030, who will need to undergo knee or hip replacement. And as you could see, the fast expected rise of knee replacements in the United States alone. In fact, an economist told me that if we don't bend this curve, it will bankrupt Medicare, which is the largest insurance in the United States. So this is a sort of a fast-growing, more than 1 million knee replacements are done in the United States alone. So this is a sort of a highly utilized treatment that's growing in a condition that's increasing prevalence in large part because of the aging of the population of the world and also the rise in obesity, which is associated with knee osteoarthritis. So the problem, though, is the use of this treatment varies markedly. And minority patients, again, are less likely to undergo this treatment, and it's not known the reason. So this is some of the evidence base to show this disparity. There has been numerous studies using the Medicare databases that have shown, for instance, African Americans in the United States. By the way, the treatment is paid mostly by Medicare, paid for by Medicare. So it's not just sort of an insurance issue, and I will get to that in a minute. So minority patients are significantly less likely to undergo this treatment compared to non-minority patients in the United States. This is actually the work done by Ashish Jha, who many of you may know as the sort of the COVID czar at the White House. But before he became that, he used to be a health disparities investigator just like me. And this is the work that he sort of published a while ago. And as you can see, Black men are significantly less likely to undergo knee or hip replacement compared to white women, even though the prevalence of osteoarthritis is actually higher among Black men. So the indication for the treatment is actually more prevalent in many minorities, yet the utilization of the treatment, this particular surgery, varies markedly. This is actually data from the CDC showing Black-white differences. What's remarkable is that not only is there a difference in the use of this treatment, but that difference is actually getting wider. In other words, it's actually being sort of increasing. So one of the problems in using the large databases to study this issue is that it's always difficult to have a good definition of the denominator, because osteoarthritis is a chronic disease. It takes a while. So it's important to really define the indications for the treatment to be able to sort of say there is a difference in the utilization. So this is a study done at the Brigham and Women's Hospital in Boston, where they actually collected patients for an NIH-funded clinical trial. They had to have severe end-stage osteoarthritis of the knee, and they followed their patients to see who underwent knee replacement over 2 years, and this is what they found. And this curve really sort of also validates what we have seen using the Medicare databases. So is it unique to the United States? So it turns out that I was actually asked to write an editorial for a major analysis that came out of England, looking at sort of the racial variations and ethnic differences in England of knee and hip replacement. And it turns out that actually the same issues have been observed in the English healthcare system. So what is the reason for this? Let me just quickly, this is a conceptual framework that we use to sort of organize our research approach. Well, one possible reason is access to care. Is it because these are very expensive treatments? If minority patients are socioeconomically less well off, it's possible that they have no sort of access to the treatment. So how do we find what's the best way to understand whether access to care is the reason for this disparity? Well, this is what we did. We went to the VA healthcare system, which is actually the closest in the United States you would ever come to for an equal access to healthcare system. Anybody who has served in the US Army, who has access to the VA healthcare system, has equal access to care. So it's a great way to actually study the role of access to care as a confounder in these sort of variations. And what we found in a cohort of patients, 260,000 or more, was that African Americans were significantly less likely to undergo the treatment compared to white patients. The odds ratio was 0.72 in the VA system, where access is not a problem. And in fact, when we followed some of these patients to the orthopedic clinic, we found that the odds ratio remains the same. So in other words, this disparity, adjusted for age and gender and comorbidities, that's found in the VA really tracks well with what we have found outside of the VA in the United States. Well, if it's not access to care, if it's not about insurance, so what else could it be? It could be about patient factors. After all, this is an elective treatment. It's what we call preference-sensitive treatment. So you don't have to have knee or hip replacement. So therefore, the patient's discretion has a lot to do with whether the patient undergoes the treatment. And there were no studies until we started looking at this. What are some of the patient's thoughts about joint replacement? Do they trust the system? Do they trust the orthopedic surgeon? So we did a study in Cleveland where we assembled a cohort of patients, 50% African American, 50% non, and we sort of said, what are your perceptions about joint replacement? And this is what patients told us. Minority patients in the blue were significantly more likely to endorse all kinds of treatments. But when it came to knee or hip replacement, the last one, everything flipped. They were significantly less likely to endorse this as a sort of an option in managing osteoarthritis of the knee. We then also looked about their expectations, because if they have a different set of expectations on outcomes, well, then that also explains their lower sort of perception or preference for the treatment. And we found that minority patients were significantly more concerned about surgical outcomes. They were concerned about pain after the treatment, the recovery period, and things like that. So there is a significant variation in the attitudes as well as the perception of the treatment. And this being an elective treatment, it has implications. We then asked all of them, if your doctor were to recommend joint replacement, these are patients who all had the criteria, who met the clinical criteria for joint for replacement, would you sort of agree to the treatment? Minority patients were about 50% less likely to say yes to that question, even when we adjusted for their familiarity with the treatment, as well as some other sort of factors, such as educational level, household income, and radiologic severity of the disease and their disease state. So in other words, minority patients were significantly less likely to sort of opt for this treatment. But when you really look at where the expectations on surgical outcomes fits into their thinking, you see how the odds ratio went from 0.51 to 0.86, and it was no longer statistically significant. That suggests to us that part of their really perception is driven by their concerns about the surgery itself. So the last thing we also thought about was, well, what about the orthopedic surgeon? 96% of orthopedic surgeons in the United States are white men. Could they be sort of preferentially not sort of offering the treatment to minority patients? It's not an unreasonable question to think about. So we did actually a study to look at this. We audio taped orthopedic surgeons and patients talking, and then we looked at what's the likelihood of recommending the treatment, all else being equal, between minorities, comparing minorities to non-minorities. And what we found in a series of models is that minority patients were about 40% less likely to be recommended for the treatment in an unadjusted model. But if you actually take into account their baseline preference, willingness to undergo the treatment, that difference went away, and it was no longer statistically significant. So in other words, the orthopedic surgeons weren't really necessarily denying something. It was just that the patients are influencing the decision of the orthopedic surgeon. And if the patients really don't know the treatment well, they don't understand the risks and the benefits of the treatment, the community members aren't getting the treatment, then I think there's a chance that they may not communicate to the doctor as effectively, and therefore the doctor is less likely to recommend. So we found that perception is different between minorities. Education is one potential way of addressing this difference between these two groups. And we sort of said, well, let's do a clinical trial. So where we use education as a way to close the gap in understanding between the patients, white as well as non-white patients, and see how that impacts sort of the process. And this is a sort of a study funded by the NIH. We did a 2x2 factorial design. Decision Aid, which is a 45-minute video that's evidence-based, Cochrane Library approved, was used to educate patients about the risks and the benefits and alternatives to surgery. And we then looked at what happens to their willingness, their expectations, and what happens to them. Just to make a long story short, this was just sort of how the trial was done. We randomized 639 patients, and we followed everybody and analyzed almost all of them. And what we found is that our educational material did actually increase their knowledge. They became much more knowledgeable, and their preference for the treatment actually changed significantly over 3 months. And then, of course, this was a one-time intervention, so of course it wanes eventually. But what this really said to us was that you could actually reshape a patient's thoughts and thinking and knowledge about a treatment. And that may actually help them. Well, we were criticized for using a very soft outcome, patient preference, willingness. So we were asked, well, could you show us a trial that shows that by doing these educational interventions, you could actually change the receipt of the treatment, the surgery? So we got NIH funding to do exactly that, and we did a study, a randomized controlled study, where we intercepted patients before they saw the orthopedic surgeon, and we subjected them to the decision aid. This is the 45-minute video that tells them everything they need to know, so they were well informed by the time they sat down with the orthopedic surgeon. And this is what happened. Both in the intention to treat analysis as well as per protocol analysis, what we found was that patients who underwent the sort of educational intervention were significantly more likely to undergo knee replacement within a year. So I summarized this finding in a sort of a perspective in the New England Journal of Medicine, where basically I made the case that actually one of the ways that we may be able to intervene on some disparities is to educate patients better and empower them with information so that they could have a better conversations, particularly when you're talking about choices in healthcare, which is becoming increasingly more and more, and choice is really sort of shaped by your knowledge, your understanding, your socioeconomic background. So that's really sort of, in a very quick summary, how we have used sort of different types of research to address a health system and maybe perhaps a health policy question. So where do we go with this? Well, we are just writing an R01, which Jackie beautifully articulated. So we're calling it the fourth generation health disparities study. It's an implementation study. It's a type 1 study where we're basically sort of saying, we're going to use this intervention and make it available to all of our health system people so that we can sort of see what it does. But we also found that readmissions have become a major focus of policy in the United States. And whether patients bounce back after they have had their knee and hip replacement and were discharged home is really an important subject of research in the United States. And our team has been actually sort of doing some work that sort of takes us away from our patients getting equally access to the treatment and more about what happens after they have had knee surgery. And we are actually working with some health economists to look at how some policy sort of interventions nationally are sort of impacting this particular disparity. And again, this is I'm just cutting to the chase to tell you that we are looking at how one of the first mandatory bundled payments in the United States as a sort of health reform, health financing reform intervention is impacting this particular disparity. And this is, again, looking at how that process has impacted minorities. And the last thing I was going to say is that one of the problems some policy interventionists sometimes do is that they inadvertently actually exacerbate disparities and inequalities. And this is an example of how once the orthopedic surgeons were told that they have to coordinate their work with the rehab people and the nursing homes, and they are accountable financially to that, they have to, of course, start cherry-picking their patients because they can't afford to just operate on anybody. So look what's happening to minority patients, particularly African-American patients. The utilization rate has gone down. So the disparity is actually increasing because of this new policy. Let me end by telling you just a quick sort of a take on this patient. This is a patient I saw. He's a 55-year-old man who served in the US Army and came to me asking for a wheelchair. And he was on pain management. And I said, well, what's the problem? And he said, oh, my knees are shot. Or my hip is shot, he said. And I said, wait a minute, have you seen an orthopedic surgeon? I said, no, I don't want to be cut. I don't want to be operated on. I said, trust me, let's talk about this. And so I went through the process. I shared with him the decision aid. And then I sent him to an orthopedic surgeon at Penn. He underwent the hip replacement. And within 6 months, he was off of the narcotics, and he no longer needed a wheelchair. That's really sort of, it's an N of one, but that's really sort of what some very focused research can help us do in the delivery of healthcare. So with that, thank you so much, and thanks for having me.